All right. Good morning, everybody. People are trickling in. Thank you for coming in the 1 degree weather. Um, it's my real pleasure to introduce our esteemed speaker for today, Dr. Anna Barak, who's joining us from Inova, where she is the Danilo Chair and Director of Cardio-Oncology and Professor of Medicine. She has an impressive list of over 200 publications, and her scholarly work demonstrates her steadfast commitment to improving patient care with research that really prioritizes issues that are important to patients, from pushing the envelope to demonstrate that HER2-targeted therapy can be safely given to patients with mild cardiomyopathy, to improving prediction models and tools for patients with cancer. One can imagine the patient in clinic that inspired her research questions. Dr. Barak has chaired multiple society guidelines and scientific statements and is an associate editor of JACC Cardio-Oncology. She's a generous mentor and colleague to many and a true leader in the field of cardio-oncology and cardiovascular imaging, and really excited that she could join us today. Thank you.
Oh my goodness. Thank you so much. And it's a true pleasure. Whenever I give the talks and travel places, I feel grateful because I get opportunity to meet new people who inspire, and I think are in many ways they are the reason to do new things and move the field forward. So you have many leaders, Dr. Usha and Asnani, among them in the field. So thank you for the invitation. I'll try to cover the learning objectives. So my goal for today is to identify shared risk factors in heart failure and breast cancer, to recognize current clinical practices for cardiovascular monitoring during breast cancer treatment, to define opportunities for risk-based heart failure prevention, and then summarize the permissive toxicity approach. So over the last 2 decades, there has been a pretty much steady state when it comes to breast cancer incidence. This is from the breast cancer statistics that get published every couple of years, showing that incidence of breast cancer has stayed pretty stable across different races and ethnicities. But breast cancer death rates have consistently been going down, particularly for the populations where the incidences has been the highest. I feel that coming from, these are cardiology grand rounds, and as a cardiologist, I feel I learned a lot from going granular in the oncology field. I think the specificity with which now we know about each of the subtypes of, so on the x-axis are the subtypes of breast cancer, because today when a patient comes to the clinic, an oncologist will be able to tell them their prognosis depending on the tumor subtype. So this is hormone receptor positive, whether it's a HER2 receptor positive or negative, and then broken further down by the race and ethnicity. So that all has resulted in really a huge increase in cancer survivorship, and these are now general numbers and estimates, not specific to breast cancer, but we have unprecedented growth of cancer survivorship. And I just wanted to, since the theme was heart failure, I wanted to just put on the side the prevalence of heart failure that has grown, and this is from NAMES study with projected increase. Of course, not this is sort of contrasting two sides, but you can imagine that there is going to be a significant component of patients with cancer who are going to be in those rising bars at risk for heart failure. So there's definitely a population level need. This comes from the concept of shared risk factors is not new, it's quite old. And this comes from the AHA statement now in 2018, putting forward a title of intersection between cardiovascular disease and breast cancer. And we've known that age, diet, physical activity, obesity are shared risk factors. I think what's exciting about 2026, so we've learned more detail about this, and we are getting more being in a position where the two disciplines are working together, trying to address them. So I'll try to cover a couple of more recent publications in the area and where we could go. So this is from a paper by Emily Lau in JACC Cardio Oncology, where she looked into how cardiovascular risk factors are associated with future cancers, so incident cancer. She analyzed the participants coming from Framingham and PREVENT study and looked into the association. So we need to have well-characterized cardiovascular cohorts. And she looked into the baseline cardiovascular characteristics, how they lead to development of cancers. Again, many of these publications that we see you'll see are at the very surface. So we collect all the cancers. In this case, these were adjudicated outcomes, and they collected the numbers for GI, lung, prostate, and breast cancer. But what was nice and interesting about this paper is that we looked and tried to break it down in different groups, so by cardiovascular risk factors themselves, or by atherosclerotic CVD risk that we use in practice. So what was interesting is that even after the adjustments, there was a steady increase. On the top, we have in blue, it's the line of the of ASCVD risk of more than 20%. And you see how that leads into over the years, that leads to increased incidence in cancers. This was true as a group analysis for all cancers. What was interesting that in this analysis, 18% of the patients of the population was the one with breast cancer, and the only cardiovascular identified risk factor was current smoking for association. But again, as a group, a significant trend. They also looked into analysis about correlating AHA's Life Simple 8 and BMP and troponin, and differences were all trending towards significant. So this is a study also now, we try to, where epidemiology has really been helpful to inform the field, looking into the cohorts that do have that identified cardiovascular characteristics, which we often don't find in cancer clinical trials. So this is a study from Women's Health Initiative with more than 8,000 WHI participants who later during the study developed invasive breast cancer. And this study looked into the association between pre-diagnosis cardiometabolic risk factors and death after breast cancer. So this is not now incident, this is the death after breast cancer. There was a strong association between the number of, so more cardiometabolic risk factors, higher the risk of death. That association, then we analyzed association with a cardiovascular death. Not surprisingly, individuals with 3 or 4 cardiometabolic risk factors had higher, and they are in green here, they had higher list of cardiovascular death. There was a trend, but not significant when it comes from the death from breast cancer, but even a signal, and this was similar to what was seen in other studies. The more patients have led to stronger associations. And then, not surprisingly, the higher cardiometabolic risk factors, or more 3 or 4 cardiometabolic risk factors, were associated also with other causes of death in this analysis. So these are just 2 examples to tell you what kind of studies have informed these concepts that now are present, coming in both of our lead journals, and informing, I think, the studies that are to come. So the concept of cardiovascular disease and cancer with a bidirectional relationship has become present. And I think it's really shaping the current research. So while cardio-oncology, in a simplified way, really started with a question, what is cardiotoxicity? I think that we've acknowledged that it's very often the very same shared risk factors that are probably underlying that event of a heart failure that we are seeing in patient that could have been contributed by the drug. But it might, there's so many other components that we may not understand, and has also led to a concept of reverse cardio-oncology that is informing, where we are seeing, just like shown in these studies, that there are cardiovascular risk factors that may be predisposing cancers. And that will live in an exciting time when that's hopefully going to start informing the therapies. So what are we clinically doing about this? This, again, nice development across the professional societies. This comes from the European Society of Cardiology guidelines, now published several years ago, where I think I'm putting them out really just to introduce a concept. Just 10 years ago, we did not have this concept of the cancer treatment continuum present in cardiovascular risk stratification. The patient comes, but in the setting of an oncology patient, it's critical to understand, are they at the time of diagnosis, and this is current diagnosis, this could be a patient with a prior cancer, but just the concept understanding that their cardiovascular risk will live somewhere on the y-axis, and I put there our nice stage A through D heart failure as example of the height of the risk. That risk will always go higher during treatment, and then during survivorship, it's going to be modulated by a number of factors. So when we see patients in the clinic, we have to think of where they lie in the spectrum of the oncology treatment. And then I really want to, as I said, I thrive from learning from others. And this was a wonderful statement that Dr. Upshaw made a major contribution to. This is a Heart Failure Society Association statement. And the point of this central illustration was to illustrate how we have stages A, B, C, and D of heart failure and where the evidence lies. So this is, of course, the overarching statement about all oncology therapies and how they could interface with the heart failure. But relevant to this talk is we really mostly know about stage A, meaning that we get data for stage A based on the clinical trials, oncology ones, where we get reported that by giving certain drug, there was a higher risk for heart failure in this case. And that becomes, okay, that patient, if they've gotten anthracyclines, they're going to stage A. If patient is hypertensive, they're stage A. So essentially a lot of data points for stage A. Stage B is, as you all know, characterized by the abnormalities of the structure of the heart, and we don't always have that information. That's now available really only for anthracyclines and HER2-targeted therapies that were followed in clinical trials. For most other patients, we don't follow asymptomatic stage, so we essentially don't know much about it. And then we are really in deep, and it's sort of like a cliff there, where we have almost no data on how, at least from the trials, on how to differently treat the patient. So we extrapolate from non-cancer population when it comes to stage C and D heart failure. So I will give an example. As Chanika said, I do get really inspired by my patients. So, and this is one of these examples that sort of keeps me up at night and makes me always redo the slides for these talks. So if we have a 30, we'll give you where we are today, and there is a clear discrepancy about how we monitor. So this is, if you have a 30-year-old woman, left-sided stage 2 HER2-positive breast cancer. She's a former athlete. She has no cardiovascular risk factors. Her treatment plan standard would be neoadjuvant chemotherapy. She will get a conventional chemotherapy with paclitaxel and carboplatin, and then trastuzumab and pertuzumab are HER2-targeted antibodies, and she will get that after. She will start with that treatment, then surgery, adjuvant radiation, and then she will continue trastuzumab and pertuzumab for 1 year. This woman, because she's receiving trastuzumab and pertuzumab, she will definitely have an echo at baseline. And then the package inserts for trastuzumab and pertuzumab will recommend that she gets an echocardiogram every 3 months, because that's how clinical trials with these two drugs were done. And they have assured really excellent safety. You saw the survivorship of this woman, probably that would be a range north from 90%. And the drugs have gotten very safe, with the safety included in them that in the clinical trials, if that ejection fraction at any point would decline to less than 50%, the patient would be excluded. So I'm just illustrating how cardio-oncology has evolved from there. At the same moment, you can have a 67-year-old woman, left-sided, all similar breast cancer, but very different in the oncology world because they will say, well, this patient has a HER2 negative and ERPR positive receptor. She will also have surgery, she have radiation, she will have probably non-anthracycline chemotherapy because she has multiple risk factors, age of 67, and she's going to have hormonal therapy. But this patient, in most instances, including in my institution, will not get an echo. You could say, why? Well, this patient has much higher cardiovascular risk and cardiometabolic risk. Why are we not getting an echo? Because she's not getting either anthracycline or HER2 targeted therapy, which are known to affect the heart function. So there's no monitoring in clinical trials. Studying these genes, there was no cancer treatment-related toxicity, and therefore this patient will get no monitoring. So now we could argue a lot about, an oncologist would say, well, if my treatment is not going to give any heart failure, why would we be getting an echo at this moment? What this also ultimately leads is that these patients are not referred. We often don't see them, and their optimization of their cardiovascular risk factor is not done. So that drives a lot of, I think, discrepancies that we see in here. So this was the question from the previous. So this is to illustrate there was a lot of controversy about the ESC guidelines when they came forward. And this is, again, cardiovascular toxicity monitoring in patients receiving HER2-targeted therapies. If you look at the transthoracic echoes, they're right there in green. 3, 6, 9, 12, and then 1 afterwards. That's taken straight from the package insert. A lot of people argue, well, there was no clinical trials, but you also could say, well, you cannot go against the package insert. So this was nicely debated in the JACC Cardio Oncology. Dr. Sperano is a medical oncologist, and he contrasted ASCO guidelines from 2017, which recommend at baseline, you should get a 2-dimensional for trastuzumab. You will get the baseline echocardiogram frequency per ASCO guidelines to be determined by healthcare professional with clinical judgment and patient circumstances. I absolutely agree with that because the guidelines said, well, you don't have trials, 3 echoes versus 6 echoes. I would also argue that we should never do that kind of trial, 3 echo versus 6 echo. We need to decide what are we going to do differently after we find the results of the echocardiogram. But that's, again, how clinical trials for these specific drugs were given. I also want to point out that only about 25% of patients with breast cancer have HER2-positive disease. All others may be that patient with a high cardiovascular risk, but no echocardiogram. So I feel that the debate of how often image has to be coupled with the ASCO guidelines also recommend comprehensive cardiovascular assessment at baseline. And the question is, while the concept of to be determined of healthcare professional, we all know how we have to have like pathways of getting these patients at the point where their cardiovascular risk factors can be taken into account. So this was another study that we looked into the use of cardiac imaging. And in this study, while really they only asked the question, who are the patients with breast cancer? In a large, this was using claims from the insurance system. So we asked who got the baseline imaging, and you'll see that this is in orange is the MAGA, in the yellow is the echocardiograms. Here are the patients who got anthracyclines, and up to 90%, between 70 and 90% of these patients got baseline imaging. In trastuzumab, a little less. Again, this is at the state level. This is millions of patients. And then 47% of women, they received no anthracycline therapy, and the range of the echocardiograms obtained within the first year was less than 20%. Of interest in this paper, again, that looked mostly into imaging, we detected that these were the women with the most, with a higher stage of cancer, and they had worse outcomes. So leading to the question that maybe these were the women who really needed anthracycline therapy, but the ones who got an echo didn't get it because of the echo findings. that in much a way, I feel that this paradigm has really, it started cardio-oncology. So in the late 80s and 90s, when we first learned that anthracyclines can cause heart failure, somebody said, let's check that ejection fraction first. And if it's low, let's not do anthracyclines. That led to improved safety, but it cannot lead to, if it's the only question, and if we focus on that EF, we are not going to move forward, because you can imagine that there's a lot of debate on what is the normal EF, right? Is it 50%? Is it 53%? Is it but it will always be a problem for a certain patient, because you will lead to a concept when you could not move next. So I think that the cardiac screening practices with the frequencies have been really based in select oncology trials with select therapies, and they excluded patients at highest risk. Many of the trials that led to that, that were done in HER2-targeted therapies, included even patients with significant hypertension. They all excluded patients with EF less than 50%, and they do not account for cardiovascular risk. They did not say, we're going to do something different based on whether you have diabetes or not. So therefore, they cannot improve it. They lead to over and under imaging, because in that case, the first patient, the 38-year-old woman, was over-imaged. She got 4 echoes that she probably never needed. And the other patient was under-imaged because you don't know her risk. And the point being also taken that majority of the patients with cancer get no cardiovascular assessment for that reason, because their drug does not directly cause cardiotoxicity. So I also want to, there is an increasing awareness about a heart failure with preserved ejection fraction, and this was done also in WHI in more than 2,000 of breast cancer survivors followed for more than 7 years. This was the adjudicated cohort in WHI that had that looked only into hospitalized heart failure. So among these 2,200 women, 6.7% were hospitalized over the mean period of 7 years with HFpEF, and 3.9% with heart failure with reduced ejection fraction. So now this also points to the paradox of if you're following ejection fraction, you're not going to find these patients. And very often they can walk into the oncology offices and not be recognized because EF is normal. So we've led this paradigm. If your EF is normal, you don't have heart failure, maybe not even risk for heart failure, which in the modern era of understanding HFpEF is not compatible with truth. So in this study, risk factors for HFpEF were waist circumference. It's a theme that I think you can see now across a couple of studies, smoking history, and then hazard ratios for mortality. This is not surprising for cardiologists, who are even worse for heart failure with preserved ejection fraction than for HFrEF. So following this, we put forward a concept in JCO about the importance led by Dr. Michael Simon. He's a medical oncologist in Detroit, pointing the importance of really educating about different heart failure phenotypes, the oncology community. Because for many years, we've told them, they learn, well, send the patient for MAGA. If it comes back with the EF of more than 50%, the patient is fine, which is absolutely not a reality today. So as Jenica said, I do always walk into clinic and think, okay, what can I do about this patient? So this is really one of these studies that takes you 10 years to answer. So can we predict when a patient comes? It's often a question. We know that anthracyclines and HER2-targeted therapies, in this case, we focused more on the anthracycline question, but we know that these 2 targeted therapies put the patient at the higher risk. But you saw those, what I don't know is how much. So the patient is, when we want to weigh the risk and benefit, the oncologist will say, if I give anthracycline, I will get 4% more recurrence-free survival at 10 years. And I will say, I don't know how much more heart failure I will get. This patient might have diabetes, might have hypertension, might get heart failure anyway. I wanted to know how much more, how can that risk of the heart failure in a long run be quantified? So this was a study that we did in collaboration with Irina Hack at Kaiser Southern California. So it included 26,000 women who, it's a retrospective analysis of the healthcare system data so we took all women who had newly diagnosed invasive non-metastatic breast cancer. We excluded women with age 80 and older, who had history of heart failure or cardiomyopathy at the time of diagnosis. And then we also excluded women who got HER2-targeted therapy and anthracyclines together. And the reason for that was purely the scientific rigor. In the California population, this combination is less used. We know that this combination leads to higher risk, and we knew that it was going to skew the analysis because only very few patients got it. So after a discussion with the statisticians, we took those out. We divided the population into 60% was derivation cohort, and then 40% into validation cohort. And then we first looked into the Cox proportional models to understand, we wanted to use only clinically available factors. So if you walk in a clinic, it has to be available. Age, race, ethnicity, cardiovascular risk factors. The advantage of Kaiser system is that risk factors are captured. So diabetes, hypertension, obesity, and smoking. So we looked into all of this, and our outcome was heart failure or cardiomyopathy defined by the ICD codes verified in the charts. So we looked into cardiovascular diagnosis and conditions before breast cancer. So if a patient we worked on the codes on other conditions defined as arrhythmias, and we also included or revascularization, so cardiovascular events, not heart failure, which was excluded. Then we looked into chemotherapy. So the patients, we grouped them as patients who received anthracyclines, HER2-targeted therapy with non-anthracycline regimen. I already said we excluded that combination, and then non-anthracycline and non-HER2. That would be that patient that I showed you earlier. And we collected data on endocrine and radiation. So based on the Cox proportional analysis and the scores, we developed a risk score. So each of those each of the risk factors that was associated was assigned a score based on the level of the association. And here are shown the scores, risk factors that were significant. So again, age, race, we pushed, of course, the chemotherapy to understand, and you can see the weight of anthracyclines, 11 versus HER2-targeted therapy, 8 versus non-anthracyclines, which were carrying 3. So summarizing those scores, we were able to divide our population in a population with low score, which was 0 to 17. You get a score, again, summing up your risk at the time of diagnosis. Moderate score, 18 to 34, and then high score of more than 35. So, and this was now in the population, we looked how this risk score is going to perform. Patients in low score had a risk of, at 5 years, 1.1 hazard ratio, and at 10 years, 1.7. The moderate score was associated with, I meant the percentages, sorry. In the moderate range, in moderate score, they had a risk of 3.4% and 6.3% for heart failure and cardiomyopathy at 10 years. And then finally, in a high score of more than 35, they would have a heart failure risk at 10 years of almost 20%. So this is now how this looks on the Kaplan-Meier curves. Again, how those 3 patients who at the time of diagnosis were falling into the low, moderate, and high risk score, how they would fare. What I thought was most relevant, going back to my question, if the patient is in the at the time of diagnosis that they present, we wanted to group it based on the age and then chemotherapy. So if you imagine what I think is I think this is the sort of the key point of this study. If you have a young patient in green, for example, getting anthracycline, it's still going to, and those standard deviations on top are mostly driven by those additional risk factors. Even if you have a young patient even with the significant risk factors, age will still drive it. They're still probably going to be in the low score, very few patients making it into moderate. In the age of, and that's where the treatment matters. I think this also reflects the clinical practice. Most young patients who have aggressive cancer will get anthracyclines, but their risk will be slightly elevated. What's interesting is I think when you come to the age 55, 64, then no chemotherapy, you're still going to be at a moderate risk. It's not surprising. Anthracyclines and HER2-targeted therapy will push that risk. So monitoring is needed in this group. And then non-anthracycline therapy is also associated with risk. So all of those patients should probably be looked at. Finally, for the women above age 65, what I think is interesting is they're all in they were all in the group of a higher risk, or majority of the women were falling. So that explains that patient, and sort of helps me illustrate how that patient who, even if they're not getting anthracycline therapy, they probably need the assessment to make sure that their risk is optimized. So this was published last year, and we are looking into how to incorporate so it's going to need external validation. And then most importantly, I think the plan of what do you do with this kind of information at the time of diagnosis. So I'll switch quickly and just show you some examples of, there are two approaches. So primary, as I said, most of our clinical trials have done in the primary prevention setting. So the patients who have normal, defined as by ejection fraction. And this is that ASCO clinical guideline from 2017 that really tried to address questions, which preventive strategies should be done before and during therapy. So most of the prevention trials try to say, if a patient is coming into and receiving treatment for breast cancer, what can we do to reduce the risk of cardiotoxicity? So I give you this background, and now I think with that, we'll cover just what kind of studies we've had over the last probably 10 years. This is a wonderful review by Thurber Omland in JACC Cardio Oncology that puts forward, you see that the treatments that were primarily studied are again anthracyclines and trastuzumab. That means a lot of breast cancer patients. And they grouped it into preventive strategies, can be general preventive strategies, and then cardioprotective interventions. I will try to go really quickly because this is a whole field, while focusing first on cardioprotective interventions. So dexrazoxane, neurohormonal agents, and statins, and then general, which mostly studies included a combination of exercise with lifestyle modifications. A quick one on dexrazoxane. You have the world's expert here on dexrazoxane in clinical practice and in the basic science. So I'm not going to belabor this, but this is just how it applies to breast cancer and how it explains why sometimes even we have a great drug with a lot of evidence ends up being not used almost at all and probably not needed. So that could be an argument, at least in the current. So dexrazoxane is a agent that works as an iron chelator and has many additional molecular mechanisms, but it was first studied in women with metastatic breast cancer. And this is a meta-analysis by Ariane Macedo, where she looked into all the studies that used, so more than 2,000 patients treated with anthracyclines and receiving dexrazoxane at the time of the treatment. Dexrazoxane has to be given as IV preparation just shortly before doxorubicin is administered. So then they analyzed in this study how the patients fared. So when they looked across the studies, there was a significant reduction in clinical heart failure across all clinical trials in both clinical heart failure and cardiac events, with the risk reduction shown as here. So this is probably the most size-wise, the most powerful intervention we have. However, in these same studies, there was no statistically significant effect on oncological outcomes. However, the devil is always in the details, and in this case, it is included in the FDA package. In some of the trials, and you can see them there in blue. These were all patients with metastatic breast cancer at a time when anthracyclines were used much more in the metastatic breast cancer setting. And they noticed that in one of the patients, in one of the groups, the patients who were randomized to receive dexrazoxane had a lower response rate and a shorter time to progression than patients who were randomized to receive a placebo. It was not seen afterwards, was not confirmed, but really led to almost absence of the use of dexrazoxane in metastatic breast cancer patients because of the concern for the oncology outcomes. What has also happened over the years in the metastatic breast cancer, the field has evolved. We now have the liposomal doxorubicin is used much more, and there's no point in using, that's a different approach. So despite really a strong signal towards protection, this was not adopted. I'll use only 2 slides to cover many trials and many people who tried to use neurohormonal agents, including beta blockers, angiotensin receptor inhibitors, to prevent cardiac dysfunction. Again, all of these trials were defined cardiotoxicity as a change in EF or variation of that. So if the EF drops, that counts as cardiotoxicity. So you can count it that way, but they all relied either on echocardiography or on cardiac MRI to define that. And I don't need to go, even though some of the trials there are relevant for many patients who may need beta blockers or ACE inhibitors. I feel that we always use them if we can, but I think if I can summarize, they were all stage A. Cancer treatment included anthracyclines, HER2-targeted therapy. Primary outcome definition, again, changes in EF, short duration, usually during treatment. So if they were receiving anthracycline only a few months, and results were small signals of attenuation of LVEF decline. Some were positive, some negative, depending on how they defined that LVEF and which technique they used. But ultimately, no major impact on clinical practice because we felt that most of the patients didn't need it. I think this is a quick summary for the statins, and I picked the trial that was led by Greg Huntley because it was done in breast cancer patients. There was a trial that published later by Tom Nealon in the groups with Dr. Upshaw and Asnani that looked into the same effect of that asked the question about atorvastatin versus placebo in lymphoma patients, which was positive, but I think relevant to breast cancer population, I'm not sure that we can extrapolate. So in this trial, they took 279 patients, 85% of them were breast, randomized to 40 milligrams of atorvastatin or placebo, and they had no difference in left ventricular ejection fraction measured by cardiac MRI at 24 months before the groups. So, and that was whichever way it was split. So 2-year worth of follow-up, very, very well phenotyped. And one of the perhaps questions is that most women, as you can tell, started with the EF well north from 55%. So in this case, this was the placebo and statin, look in the 60% at baseline, and then small decline at the 24 months, but that is still well within the normal range. So no significant effect, and one could say maybe the effect size is really because the risk was so low. There were no clinical heart failures of significance in essentially 1 or 2 patients in each arms equally distributed. So I will move quickly. Then we said, well, can we stratify patients? Can we find patients who are at higher risk? And the study led by Dinesh Tavendarathan, they looked primarily into global longitudinal strain. Now we'll move quick. This one asked the question, can GLS-guided cardioprevention versus LVEF-based cardioprotection, can that improve the outcomes? So this was a SUCCOR trial that randomized 330 patients, followed them. One of the frequent misperceptions of this trial is that all patients received the same every 3 months surveillance. And in this case, if they were in a GLS guided surveillance, then the patient, when the GLS would drop, so global longitudinal strain would drop, they would get started on cardioprotection. In the LVEF group, they were waiting that EF drops. When the EF drops, they would start the cardioprotection. They did a 1-year analysis and a 3-year analysis, and they were not different. The trial did not meet the primary endpoint, which was the difference in EF at the end of the 1 year. But I think this is the most important part. If you look on the top, these are each individual patients and EF who received cardioprotective therapy. So this is in the GLS group, and this is in the EF group. You can almost immediately see that many more patients received cardioprotective therapy in the GLS guided group, and in the EF group, there were fewer of them. You could also see how EF was lower. So separate analysis of this of these two groups was significant, but the vast majority of the patients didn't need anything because they had no change in EF and they had no change in strain. So the trial was negative, led primarily by the vast majority of the patient having steady normal EF. And I think that explains all the other primary ones. Most patients do not have risk or their ejection fraction doesn't change significantly. So whichever prevention you do, you're not going to make a major impact. So I will move, put forward, there was a lot of criticism about the trial saying that we need to abandon strain, it's not helpful. It's still one of the most important informants about the overall risk. Every study that looks into is going to find lower strain associated with the risk for heart failure. So our message here was, I think we are like killing a messenger. There's no signal in the studies, but you have to identify patients who actually may benefit. And to the credit of the group, they did publish subsequent study in which they took 330 patients from similar, most of them with breast cancer. They looked at the MRI here for the outcome for the EF, but they stratified only, they randomized only patients who had a decline in strain. So they have, of those 300, only 100 patients had isolated reduced ejection global longitudinal strain. All of these patients had to still have normal EF, otherwise they would be taken out of the study. And then they randomized them to cardioprotection versus usual care, and they did find significant difference. So the patients, just like the signal that they saw in the first core, the EF dropped more in patients who, after seeing that strain has dropped, didn't do anything, versus in the ones after the strain dropped, they were started on cardioprotection and EF drop was less. So I think that this is a real signal. Now we can all debate whether that makes a true difference, whether EF in the end is 55 or 59. But I feel that you have to look at ask the right question at the population of risk. So now many studies and much more excitement about the exercise. They're harder to do. So they are that general prevention studies. And I'm going to just show brief. Most studies looked at both ejection fraction and MVO2. And if I need to summarize them, they, in general, exercise studies, taking women with breast cancer, starting anthracyclines, and randomizing them to intervention versus usual care. Most of the studies will show the difference between, in this case, they call it functional disability, but it's a VO2 peak that matters in these patients. So exercise favorably affects the VO2. And that has been shown now in multiple studies. Jessica Scott, this was a Brexit study from the Australian group, showing again across the board the improvement in the MVO2, which was not the case for the left ventricular ejection fraction. The Jessica Scott's group from Memorial Sloan Kettering, they looked at the timing of exercise when initiating adjuvant therapy. This tells you just how complex they had a very complex schema during chemo, after chemo, overall comparison. And then they also ask a question, do you need to continue all across? Ultimately, they showed a difference in the VO2 peak change, summarizing that the best effect were in the continuous therapy. So you had to start exercise at the time of the initiation of chemotherapy and continue it afterwards in order to achieve that difference. So you could say, well, this exercise will improve cardiovascular health. Even though we don't have evidence for EF, we already said the risk is probably larger, functional capacity is huge. And then we have a whole literature of how exercise improves the tolerance of chemotherapy. I think this was beautifully summarized in just this last October in a JCO by Dr. Lidgeveld from Dana-Farber. And in a summary saying that if exercise were a pill, we would all prescribe it to the patients. We have enough basic science evidence, clinical evidence on many things that it improves, but we don't. And the answer is it's not a pill. So in order to prescribe it, you need to know the dose. You need to have behavioral support mechanisms, to have access to exercise professionals. You need to be able to triage and assure access for the patients for the to the exercise. And I feel that this is one area where there's probably the strongest overlap between cardiovascular improvement. We think of the general strategies in that can improve cardiovascular health, reduce cardiometabolic risk, and in oncology on working and finding solutions for these patients. So this is really a concept. Again, I learned a lot. I have a privilege of being in the AHA committee with Dr. Asnani. And I think a lot of these sort of visions of how can we do things and what do we need has come from the groups that come together that way. So this is now all in 2019. Where we proposed a concept of creating cardio-oncology rehabilitation using cardiac rehab as a model. Again, whomever is interested, I love your thoughts on this because I think it's a still very valid idea, and it becomes even more important at a time when we know that it improves oncology outcomes. So I will spend 5 minutes on the secondary prevention strategies, which I think are getting every day more relevant. So these are patients with cardiac dysfunction. It's always about definitions. I feel when we talk about cardio prevention in cardio-onc and specific to anthracyclines and HER2 targeted therapy, you remember that slide with the EF. So every patient that has abnormal EF, and usually defined as a 50%, or has a known cardiomyopathy, then those patients would not get the treatment. So big questions in these patients is, can you actually give HER2-targeted therapy? Anthracyclines have not been studied in this way. We studied the patients with HER2-positive breast cancer, and I'll first talk about the SAFEGUARD study. It was published now 7 years ago. So we've included the 30 patients. It was a phase 1 study looking at patients who have any stage of HER2-positive breast cancer and needed treatment with either trastuzumab, pertuzumab, or T-DM1. But at the time of presentation or during treatment, developed a contraindication, meaning LVEF between 40 and 50%. So for this study, since we were using the drugs for the approved oncology indication, but out of the approved label, we obtained the IND from the FDA, and their primary outcome was the completion of planned oncology therapy. So in the adjuvant, for the all metastatic patient, that was 1 year of planned HER2-targeted therapy. And in the adjuvant setting, it was whatever the patient still needed to do or to completion of the adjuvant treatment. Scholar trial, and I will describe it in a second, was similar, but it included slightly less sick of a population. So it included only non-invasive, only stage 1 through 3 breast cancer. They all had to have normal LVEF at baseline. And these were the patients who would drop ejection fraction on trastuzumab, and they did not include other HER2-targeted therapies. Their primary outcome was the number of trastuzumab cycles after enrollment. So only a couple of slides on SAFEGUARD because it's a small study, but we still don't have a larger ones to prove safety. And I feel that we extrapolate a lot. I personally do in clinical practice. So these are all of your patients who come and they don't have normal EF. So when we looked at who the patients were who were participating, we had 42% of patients with metastatic breast cancer. Most of those patients were at that time pertuzumab and trastuzumab. This was designed in 2013 and included, this was at that time the main approved strategies for metastatic were pertuzumab, trastuzumab, and T-DM1. So you're seeing distribution. And about half of them had prior anthracyclines, whether as part of breast cancer treatment or they had a different cancer. This is the medication titration. The hypothesis of SAFEGUARD was if we start right away the cardiac medications, and we started carvedilol, we added ACE inhibitor or ARB, and it was not, if the patient was not on it, we went with ramipril, although more patients ended up having candesartan, but we did not specify it. It was not because it was obtained on clinical grounds, so study did not provide the drug. And we committed that we would restart anti-HER2 therapy within 1 month, and most patients were able to start within 3 weeks. So these were the results, and they would continue, and they had the first echocardiogram was in 6 weeks, and then afterwards every 3 months. So our primary endpoint again was the number of patients who completed planned therapy. Of 30 patients, 27 completed the therapy, and then we had 2 cardiac events, which were both heart failure, and we had 1 patient with a continued asymptomatic decline in the EF, but less to 30% and persistent at 4 to 6 weeks. So with that, that was the primary endpoint was met, and we concluded that in majority of the patients it was safe. We also looked into in the patients who developed heart failure, they improved. There were no heart failure deaths, not even when we looked at the 3 years. And I think I did have a follow-up. So this was now published. Dr. Philippa Lins is now with Dana-Farber, and she led this study. We looked at the 3 years of how the patients fared. So in blue on top are early stage breast cancer. So those patients would have not needed any more HER2 therapy after completion of the trial. But in gray are breast cancer patients, metastatic breast cancer patients who continued therapy after trial in most instances. And you will see that there were no heart failure deaths despite continuation. Overall, this is now a comparison of the available EF because they were no longer getting into the study, but EF mostly stayed in the normal range, and there were no subsequent heart failure events. In dark circles are the EF if it was more than 50%. And you can see that there is only 1 yellow circle for a patient who developed, dropped further EF. Again, most instances when you get the patient, some of them dropped off the study and forgot the cardiac medications, and they would improve. None of this is surprising for a heart failure physician, or even I would say a general cardiologist. I think it was really making it happen in the setting of them continuing the therapy, which they would have been excluded from. And those were the 3 patients. So this is now from from the editorial by Rich Steingart when Scholar was published in 2019. commented on how they provide strategies to allow significantly more women to be fully and thus more effectively treated for breast cancer. We need larger studies. I feel that more than the even larger studies, we need pragmatic approaches, how the granular questions, for example, I get asked all the time. Today, I treat these patients very differently. I start them on sacubitril valsartan because we extrapolate from heart failure literature. I ask myself, would they benefit from SGLT2 inhibitor if they are asymptomatic? It's really, some of them were stage C, some of them were stage B heart failure. So more granular approaches, and how do we make this, how can we continue to collect data at a larger scale? This is a very small study to be practice changing, but it was included. This is from the ESC guidelines too. And now a recommendation is to continue HER2-targeted therapy under cardiovascular monitoring. Of course, it cannot be class 1 because we don't have randomized trials. And I will conclude that the multidisciplinary approach, which you have here, is becoming a standard. We all have questions. How do you capture risk at baseline? How do you communicate that risk? How do you treat risk? And again, coming back to the professional society, I love this publication, again, by Arti and Rohan Khera on, I think we all have a lot of hope in AI, but we will have to identify those granular points and feed into the AI models to actually be able to improve care. So I'll conclude that I hope I conveyed that breast cancer and heart failure do share risk factors, that cardiac monitoring practices are largely based on assuring safety. We have huge opportunities for heart failure prevention, for early recognition and treatment of risk factors, implementation of exercise, improved understanding and treatment of cardiometabolic risk, and then to address increasing relevance of permissive toxicity that creates a platform for pragmatic collaborative oncology clinical trials. Thank you very much. I think I did go a little bit over.
I'll start with one. Yes. I've been thinking a lot about how we democratize, the growing cancer survivor population, and they're mostly seeing primary care, and and breast cancer is still seeing their oncologist. And when we see them, we think, what's their mean heart dose? What are obviously their cardiac risk factors? I'm just wondering, do you like a lumper or a splitter in terms of, do we just say like cancer is a risk enhancer in PREVENT equation, like it increases your risk of ASCVD or heart failure, and just message that to primary care that it's a risk enhancer like rheumatologic conditions or family history, or like otherwise I feel like these patients are getting missed, like their excess risk of heart failure and ASCVD.
Jenka, you always ask the key questions. There's still one, yes, you walk into the clinic and, going back to that slide, that patient has diabetes, that patient would have completed the therapy, for example, even if they got an anthracycline, right? You check you say, so do you continue to follow that patient in a subspecialized clinic that will have a number of other patients waiting, or you just say, well, you have risk factors, you also got this therapy, you need to go, and these are your goals. So you need to get this under control, you need to get into exercise trial. I'm in favor of that. I think that's the only scalable intervention. And the question is, how do we get data to support it in a larger scale? Because where it falls through is like just saying, oh, we want primary care to take care of. But I feel that the primary care can really only fulfill that if there are exercise centers, if there are, recognizing all the things that have, so to provide them with the tools that the risk actually can be modified. But I think with regards of addressing cardiotoxicity, I could not agree more. I think it should be another checkbox in the future state, sort of what's right now prevent, that in the future we would sort of prevent cardiotoxicity, and that we could try to lump as many. So, I like to dive deep when we want to understand in each cancer what to do, because the questions can be different with the cancer treatment, but on a long-term prevention, it's just another risk factor. Yes.
I can't remember the number exact out. Is it possible to parse from the data or studies that are ongoing How much of that is effect on cardiovascular health? And how much is that effect on cancer and other things?
So that is a huge question, and I have to say that editorial that I shared by Dr. Lidgeville was really driven. There was a fascinating study published in New England Journal in October called Challenge that took. I didn't show it because it's colon cancer, but they took, let's say, 1,500 patients. Took 15 years to do across the world. So patients with non-metastatic colon cancer who were at the time of diagnosis randomized to usual care versus exercise. And their primary question, they followed MVO2, but their primary question was colon cancer recurrence, because these patients are at risk. They're all going to get chemo, they're going to get treated, but they're at risk for recurrence of colon cancer. And it was a positive trial. So they were able to reduce, there was a reduced colon cancer recurrence. At 15, mean follow-up was just under 15 years. And that really drove, like, to your question, I think once you see the impact, well, you need to study many patients for many years to get that outcome. So to go to your question, I think it's both. There is a lot about the, so we know that even with the cancer diagnosis, MVO2 goes down, and it's a no-brainer. Of course, like a lot of things happen even at the time of diagnosis. Any cancer therapy, including non-anthracycline, is going to reduce MVO2. Anthracyclines have more powerful reduction in MVO2, and that's why most of the studies designed you want to follow the rigor. So you want to see statistical change on 200 patients. You go with the agent that causes the most damage, so you can attenuate that damage. And that's how it was studied. There is so much in literature. So right now, oncology guidelines have it as like in clear that exercise during oncology treatment is recommended. And they went summarizing all of that with 5 times a week, minutes, similar to the Institute of Medicine recommendations for general practice. That's how much we can extrapolate. But there are a number of benefits. What we don't have is, what I think is really clearly missing is, like every oncologist now in my institution, I see in the patient's notes, like together with the chemo, exercise is recommended. But what do patients do with that? Like the question is like, how much? Should I do weights? Is it safe? Should I go to the gym? Well, I cannot do it because of X, Y, and Z. So much more granularity is needed there. And I think that concept of cardiac rehab sort of came, like we actually have, of course, the cardiac rehab patients are very different. These are your myocardial infarction, heart failure transplant. But I think to myself, and to full disclosure, my first job out of fellowship was a medical director of cardiac rehab. So you can see I was thinking of these things. The cardiac population has also become very different. We are no longer seeing major heart attacks. And what we were, cardiac rehab, I think, was invented similar to the CCU for safety, right? But I think that risks of exercise have, long been forgotten. It's more about how do you develop individualized exercise prevention. And to make the thing even sort of deeper, I think we are learning more about the importance of muscle health and bone loss, and what exercise can do that, and how that feeds back into the cardiovascular health. So I feel that MVO2 is still, in my mind, much better marker or endpoint than left ventricular ejection fraction, but it's not going to answer to all. So can we capture, like when we design trials, can we capture cardiometabolic health? What would be that sort of rubric of health? And then we can impose exercise on that and measure it. So I think that's where it's leading. Thank you. No, thank you for the question.